If you said C, this is correct. This presentation is most consistent with hypertrophic obstructive cardiomyopathy, or HOCM, which is typically inherited and caused by mutations in sarcomere-associated proteins and causes hypertrophy of the left ventricle and ventricular septum. When the heart rate increases, the left ventricle doesn't have enough time to completely fill, and the asymmetric enlargement of the ventricular septum obstructs the left ventricular outflow tract, which leads to decreased cardiac output, causing syncope and potentially fatal ventricular arrhythmias. This patient should be started on a beta blocker or a non-dihydropyridine calcium channel blocker, be referred for ICD placement, and their immediate family should be screened. He does not have signs or symptoms of heart failure, so he does not need diuresis. Cardiomyopathies can be genetic or acquired. Hypertrophic cardiomyopathy can be concentric, which is most commonly caused by long-standing uncontrolled hypertension, with some less common genetic causes, or it can be asymmetric, as in our patient with hypertrophic obstructive cardiomyopathy, which are more commonly inherited. Hypertrophic obstructive cardiomyopathy can cause a systolic crescendo-decrescendo murmur that increases with anything that decreases cardiac filling, like standing up suddenly or the Valsalva maneuver. Patients with HOCM have impaired ventricular relaxation, so treatments that slow the heart rate or prolong diastole, like beta blockers or non-dihydropyridine calcium channel blockers, like verapamil or diltiazem, are mainstays of therapy. Patients should stay well hydrated and avoid diuretics to ensure that they do not become volume depleted and decrease their cardiac output. Patients with HOCM should also be referred to an electrophysiologist for cardiac connectivity studies and be considered for an ICD if they have a family history of sudden cardiac death or a personal history of syncope or cardiac arrest. Septal reduction by myomectomy or alcohol ablation may improve symptoms, but they do not decrease the risk of cardiac death. Heart transplant in severe cases is curative. Due to the heritable nature of the syndrome, all first-degree relatives should be screened. Restrictive cardiomyopathies are caused by infiltration or fibrosis of the myocardium, leading to impaired relaxation in diastole. Causes include heritable disorders, amyloidosis, hemochromatosis, sarcoidosis, radiation, and scleroderma. Some of the key clinical features include a prominent S4 indicating a stiff heart, mitral or tricuspid valve regurgitation, or Kussmaul sign, which is increased JVP during inspiration. EKGs will typically have low-voltage QRS complexes, right or left atrial enlargement, and conduction abnormalities. Echocardiograms will show diastolic dysfunction with a preserved ejection fraction. In amyloidosis, echoes may find amyloid speckles in the myocardium. On the NVMe, questions may ask you to identify the cause of restrictive cardiomyopathy. If you see pulmonary hilar lymphadenopathy, the cause is most likely sarcoidosis. A patient with peripheral neuropathy, a speckled appearance of the myocardium on echo, and renal disease likely has amyloidosis. Questions with patients with transaminitis, hypogonadism, and diabetes are likely pointing you toward hemochromatosis. Dilated cardiomyopathy has many potential causes, like ischemia, alcohol, Takotsubo cardiomyopathy caused by massive catecholamine discharge, postpartum cardiomyopathy, myocarditis, endocrinopathies, and genetic diseases. EKG changes can include ST segment changes, conduction abnormalities, and ventricular ectopy. Echocardiograms will show a left ventricular dilatation and dysfunction, and cardiac enlargement is often seen on chest X-ray. Patients typically present with heart failure symptoms and pulmonary edema at the time of diagnosis. Patients should undergo heart catheterization to look for an ischemic cause before working up other less common causes. Management is typically directed at improving heart failure symptoms while addressing the underlying cause. Let's try some post questions before we move on to a new topic.